Welcome to all. For those of you who don't know me, I am honored to serve as your Flex Program Coordinator. The purpose of the reverse site visit is to provide state Medicare rural hospital flexibility programs with a collaborative learning environment to make connections, share best practices, and gather lessons learned to empower and support Flex Program Critical Access Hospital flexibility. The learning objectives over the next 3 days include to replicate successful state Flex program models for empowering flexibility in today's rapidly changing environment, determine what 2020 vision looks like for improving and strengthening rural health, and to strengthen the leadership of your State Flex program in the core competencies for State Flex program excellence, including managing the Flex program. We worked with a great group of planning partners, including representatives from the State Flex programs, the Task Advisory Committee, the Flex Monitoring Team, Arquita, and my fellow FRHB staff. Thank you to all who participated in the planning committee. Our theme for this year's reverse site visit is creating a 2020 vision, empowering flexibility in rural. We hope that these sessions bring you clarity on your vision for your Flex program in these great times of adaptability and resiliency. We'll be interested in your feedback for next year, so please be sure to share your comments with us. The reverse site visit assessment will be distributed to you electronically after the event, so please look out for that email. I am very excited to announce that we have two brand new Flex project officers, Laura Seifert and Talia Chappell. I encourage you to reach out to them during the RSV through the chat pod to introduce yourselves. We have restructured the FRHP project officer assignments to align with the HHS, HRSA, and SOAR regions, with each project officer taking on a region and Region C getting the benefit of the whole team. We will be transitioning roles within this month and having stability moving forward to the new Flex program year starting on September 1st. As your Flex program coordinator, I am available to you at any time. Please reach out to me with any questions or concerns that you may have. I would now like to turn things over for opening remarks to the Associate Administrator of the Federal Office of Rural Health Policy, Tom Morris. Over to you, Tom.
Great, thank you, Tori. Appreciate that very much. Let me get situated here. And all right, well, again, I think I want to echo both Tracy and Tori and thanking you for taking the time to do this. And of course, we all would prefer to do this face-to-face, but these are historic times. And I appreciate the planning committee and everybody adapting so quickly to try to figure out a way to really leverage the technology to still have a meeting that can have a real impact on what we're doing. I think your theme of creating a 2020 vision is really important, and so I appreciate all the folks who came together to do this. In a lot of ways, doing a meeting this way requires even more planning and more thought about how to make sure that you get that engagement, and I think the group has really come up with a great way to use the technology and use it smartly to make sure that we still have the engagement, because that's what you really miss when you don't take part face to face. And yet I think we've all been on enough Zooms over the last 6 months that we've seen it done well, and we've seen it done perhaps not so well. And I do think that the planning on the front end really makes a difference, and that definitely took place in this situation. So again, I think I want to echo the learning objectives that Tori just mentioned. I think we've got some really innovative work going on in all of the states, and I think the challenge is how do we make sure that you all learn from each other so that we can replicate that works really well. Again, you have to adapt it to your particular state, but we've got a number of folks who have really done some great work at the state level in terms of leveraging these dollars on behalf of their critical access hospitals. So that's a really important thing to think about moving forward. You can't talk about the Flex program without talking about the need to have flexibility. It would sort of be a violation of the statute. So I think that we want to talk about how we remain flexible to adapt to an ever-changing environment in which the hospitals are operating. And then the core competencies are also really important moving forward. And so, as always, we want your feedback on how this meeting goes, and you all have never been shy about sharing that. I don't expect that to change this year. In fact, in some ways, having the Q&A function and the chat function provides you instantaneous feedback. So hopefully you'll take advantage of that. But before we move into our keynote with Kara James, I do want to do a quick update on some of the things that are going on within the office and the department. So I recently presented our budget and our plans for the remainder of FY20 and looking into FY21, and a couple of key themes emerged. I want to start with the work of the HHS Rural Task Force. You may have noted that last night the White House released an executive order on rural health and telehealth. It had a number of things in there that I think would be of interest to this audience. It talked about the need to really leverage what we've been able to do in telehealth during the pandemic with the extra flexibilities. It talked about the need for CMS to come back to the public with a new payment model. It talked about the need to work with USDA and FCC and expanding access to rural broadband, because that's at the core of so much of what we do right now with telehealth and with mobile health and with fully leveraging electronic health records. And then it also called for a report from HHS on how we can improve rural health. And so really, more to come on all of that. The executive order, in essence, sort of tees all those issues up. And so I want to give you a little preview of some parts of that, particularly the report that's mentioned. And in that report, you're going to see a reference to a new initiative we have called the Healthy Rural Hometown initiative. And I think that concept starts with our community-based division programs, but I'll talk more about that later. But we hope to expand it across the Federal Office of Rural Health Policy. Excuse me, and that would include the FLEX program. Closely linked to that, I think, is the notion of our need to do more around rural health disparities. I think we all know about lower life expectancy and higher mortality rates and the chronic disease burden. And yet often lost in that is the very stark racial and ethnic health disparities that exist not only within rural, but within healthcare more generally. And if ever there was a time to talk about that, I think it's this year given all that's going on in society. And I think a chance to really lead in terms of rural health in that regard. I'm sure Kara will touch more on that later. But I know that as an office, we're going to take a deeper dive and an extra effort to really think about not just disparities, but really how these play out with different racial and ethnic groups moving forward. I think that it's high time that we paid more attention to this. And obviously, COVID has driven that home in a way that I don't think any of us could have expected when you look at some of the populations that have been affected. I mentioned that telehealth was referenced in this presidential executive order, and it really is telehealth's big moment. So I'll talk a little bit more about that. In some ways, if there's a silver lining in this larger pandemic, it's the fact that we've seen telehealth move from often being couched in terms of potential to actually being a reality. And so that's one positive. The other big area of focus for the office is the response to the pandemic. And we've had an infusion of almost $400 million into our budget. To bring it to a $400 million total. And so we've had a chance to play a role in the pandemic, but so have you all. And we greatly appreciated that. And then the final area of note would be around performance measurement. And I think that I'll talk more about this later, but really this is one of those situations where our hat is off to the FLEX program for what they've been able to do. And in particular, for Christy and her team for the leadership they've shown. So I do want to talk a little bit about the rural COVID-19 response. Falls into several buckets. There's the one for rural providers, and you all played a key role in that. Those of you that are involved in Small Hospital Improvement Program, where you very quickly took $150 million and got it out to the rural hospitals. So I thank you for that. I know that was no small feat. Also, we were involved in the Provider Relief Fund and making sure that we had a rural allocation that made sense. And so you saw $10 billion go out to rural hospitals, to rural health clinics, and to rural community health centers. And couldn't be more proud of the team we have at FRHP. Sarah Young, Paul Moore, Normandy Brangan, Kerry Cornejo, and Craig Kaplan all played a key role in designing that allocation formula, and they were helped greatly in that by our Rural Research Center at the University of North Carolina. And so, more specific to the pandemic, we were able to stand up a tribal program for $15 million in less than 60 days, which is really a record time for a bill passing to actually getting funding out the door. And so we're really pleased to be able to do that. And then more recently, we're able to allocate $225 million for COVID-19 testing for rural health clinics. And, this is really important because we've never, the rural health clinics have been around since 1977. We've never had a dedicated appropriation to work with rural health clinics. And so I know the state offices of rural health are going to be involved in that, along with the National Association of Rural Health Clinics. And then finally, we have a range of activities around telehealth, including increased technical assistance for folks who want to leverage the technology. And we're getting ready to stand up some help for clinicians in addressing some of the licensure issues that you get through our work with the Federation of State Medical Boards and the provincial boards of psychology. And so anyway, I mentioned that, telehealth, it's mentioned both in the executive order. We stood up a new website at HHS so that we have a new landing place, and this is a resource both for patients and for providers. And so I think this is a real great opportunity. We've seen the extra flexibilities that have been offered through both some of the flexibilities that HHS has used in terms of the pandemic emergency declaration, but also the Congress has stepped up and made some changes during the pandemic to make it easier to bill for services and all those things. And all of this is, I think, creating a really important opportunity moving forward. The executive order I mentioned is really sort of a parallel effort of what's been going on at HHS for the past 2 years, really. Back in 2018, Secretary Azar made rural health a priority right towards the tail end of that year and created the HHS Rural Task Force. And so we spent the first year or so really sort of educating people within HHS around rural health. We did a number of listening sessions and then took some initial regulatory and program steps, including CMS making some historic changes to the including CMS making some major changes to the Medicare wage index for low-wage hospitals. And then we also released a new program around improving access to maternity care and obstetric care, based in large part by the findings of the University of Minnesota Rural Health Research Center, which showed a dramatic loss of access to OB services in rural and critical access hospitals. And so those are sort of the initial steps we took. Obviously, I did these slides about a week ago, and the executive order has sort of changed things a little bit. But we are looking forward to responding to the call by the executive order to produce a report for the White House on rural health issues. And so stay tuned for that. We're going to base most of that off an effort that began probably about a year ago this October. The Deputy Secretary of HHS asked everybody to report back on, across each agency and office, to report back on some of the things they were doing around rural health and some of the new steps they could take. And so what you'll see in this report is none of them in and of themselves are game changers, but there's a lot of activity going on across the department. And when you look at it in its totality, it's actually quite impressive. And so again, more to come on this moving forward. So we talked a little bit earlier, I mentioned the notion of the rural health disparities, and this has been something we've been thinking about in the office for a long time. And the CDC has had a number of reports coming out and showing that we see higher rates of avoidable or excess death in rural communities relative to urban communities. We have already mentioned the life expectancy and the mortality metrics. The bottom line is none of these numbers are going in the right direction. And as daunting as those figures are at a national level, we do know that we can make a real impact at the community level. And so this is where that whole notion of the Healthy Rural Hometowns Initiative emerged from. And so what we wanted to do was sort of build on some of the things we've seen in the funding we provide through our community-based programs. These are the rural health outreach grants, the rural network development programs, the planning programs, the quality improvement. We know that at the local level, even though these are big challenges, you can make a difference at the community, at a community level. And so what we want to do in the coming year is take advantage of some new flexibilities we have in the Rural Health Outreach Authority. Right now, we've expanded the eligibility of who can apply for this funding to urban entities. We were following the lead of what happened in our opioid programs, where state offices, for instance, were able to apply and be the lead applicants. And that will be the case this with our next round of rural health outreach grants and rural network development grants, all those things. And so really, I think this is an opportunity, I think, to really take that, what we've seen sort of at a micro level, and extend it across our programs. So could we do more on reducing risk? Could we do more on better managing chronic disease? You'll see the first effort towards this in the upcoming guidance for the Rural Health Outreach Program, but I think it can build on some of the efforts you've seen in Flex around population health and innovation. And so would really put this out there as a challenge to you all to join us in this opportunity moving forward, because we think that we can have a big impact. So while we're starting it with our community-based programs, we feel like it's scalable to the Flex program. We feel like it's scalable to what we do with our telehealth network grants. We also feel like we can emphasize this within our opioids efforts also, with the idea being is how can we empower rural communities to really take these issues on in a meaningful way, because we're never going to turn around those national metrics if we don't do it at the community level first. And so we're going to be doing this over the next 5 years in all of our programs and trying to emphasize it where we can, where we have the statutory authority to do so. And our hope is that over that time, we'll really be able to show the impact that we had. And so we see it as a really unique opportunity, and it will be part of what we propose in that HHS report moving forward. So, the fact is, a lot of this has been going on within our community-based division for a number of years. What's great about those programs is that they're flexible. They're basically, the grants are anywhere from 1 to 3 years, and a chance for rural communities to test out their own ideas. And so in a lot of ways, one of the opportunities for the Flex programs would be, sure, within your existing grant dollars, to the extent that you can, there's a chance to think about aligning with our goals around the healthy rural hometowns. But then just as importantly is, can you help us get the word out about our existing community-based funding? Can some of the state offices of rural health perhaps be the lead applicant on behalf of rural communities in this area? And I think that, as you think about your 2020 vision, I would ask you to fold this into it and make it a priority moving forward, because we do think there are some really unique opportunities in doing this moving forward. So I mentioned performance measurement also as a priority, and I'm just really happy with the progress you all have made on this, and the partnership has been not only with you all at the grantee level, but also with TASC, also with the Flex monitoring team, and it's been a long journey. It started with MB-QIP and really started to report on quality data, but it also moved into the financial side of things, and what's great about it right now is we can show an association between improved quality and Flex funding. We can also show an association between improved financial performance and Flex funding, and that is really huge for us. And we're building this into our budget performance each year. We feel like this is where we want to go with all of our programs, but right now this is one of our strongest areas of performance measurement across the office. And the credit, I think, goes to you all for responding to that challenge. And I really want to thank you a lot. I know it hasn't been easy to do all this. You've done a lot without a little bit of funding. And I think, Christy and her team deserve a lot of credit also for making this happen. So the thing I guess I'd like to leave you with is great job, but let's keep going. This is no time to sort of rest on our laurels, but we've got to continue to drive those links home, because ultimately the ability to leverage to have a program like Flex ultimately rests with being able to show an impact. And we put that charge out to you all probably more than 10 years ago, and I think now we're starting to see the benefits of what you all have been able to do. And so I really greatly appreciate it. I would encourage you all, if you're not already signed up for our announcements, to sign up for them. We really try to make sure that these are meaningful and that they are of value to people. We're all on probably too many listservs, but if you were going to be on 2 listservs in your inbox, one would be our announcements and the other one would be for RHI Hub. And so what we try to do is make sure that we tease out why it's important to rural in these. And so if you're not signed up, please sign up, and please encourage all of the hospitals that you work with to sign up also. And so with that, I just thank you for your time. I do want to move towards introducing Kara James. And Kara is going to be our keynote speaker. She is a fantastic partner for us, has been historically. She recently, at the beginning of the year, early in this year, right before the pandemic struck, assumed the heading up the Grantmakers in Health as their new CEO. And but before that, she'd been at the Centers for Medicare and Medicaid Services, where she co-chaired the CMS Rural Council, and she also was the director of the Office of Minority Health. And in her work there, she produced the CMS's first ever rural health action plan, and then she also produced CMS's first ever rural minority health report. And she did a great job on both those issues, and she did a great job, I think, educating the rural community that we have to think about both of those things, that minority health often gets short shrift within the larger rural health discussion. I know she educated me about this, and I think she did a good job educating a lot of folks in HHS about it also. Prior to joining CMS, Kara worked at the Kaiser Family Foundation. She has a PhD in her undergraduate degree from Harvard University, and just has been a fantastic resource for us moving forward. I mean, historically. And so with that, I think I'll turn it over to Kara, and I guess I will stop my screen sharing. And Kara, thank you so much for taking time to be with us today, and look forward to hearing your remarks.